The most commonly impacted teeth are the mandibular third molars, maxillary third molars, and the maxillary canines. Classifications of impacted teeth. They are classified by angulation, by the Pell-Gregory classification, and by relationship to occlusal plane. Okay, so the angulation classification is either mesioangular, distoangular, or vertical and horizontal. The mesioangular is the least difficult to remove for mandibular impactions. The distoangular is the most difficult to remove for mandibular impactions, and there's the vertical and horizontal. Pell-Gregory classification. The Pell-Gregory classification is the relationship to anterior border and horizontal. The Pell-Gregory classification is the relationship to anterior border of the ramus. There's three classes of the Pell-Gregory classification. Class 1 is in normal position anterior to the ramus. Class 2, one half of the crown is within the ramus. And the Class 3, the entire crown is embedded within the ramus. Now, the third classification is a relationship to occlusal plane, in which in Class A, the tooth is at the same plane as other molars. Class B, the occlusal plane of the third molar is between the occlusal plane of the cervical line, the occlusal plane and the cervical line of the second molar. And in Class C, the third molar is below the cervical line of the third molar. Contraindications to extraction of impacted teeth. A compromised medical status, likely damage to adjacent structures, extremes of ages, pre-teens, or an asymptomatic full bone impaction in a patient older than 35 years of age. Factors that make impaction surgery less difficult. The positioning of the tooth is in a mesioangular position. That makes it easier. Less difficult. Class 1 ramus. Remember, the Class 1 ramus is in normal position anterior to the ramus. Class A depth, in which the tooth is at the same plane as other molars. The roots 1/3 to 2/3 are formed. This is present only in young patients, in which 1/3 to 2/3 are only formed. The roots are fused conic roots. The periodontal is a wide periodontal ligament. This is present in young patients as well. A large follicle. This is also present in young patients. Elastic bone also. Separated from the second molar would be also another factor that will make surgery less difficult. Separated from the alveolar nerve, and soft tissue impaction, if they're impacted only in soft teeth. Now, what factors would make the impaction surgery more difficult? If the tooth was in a distoangular position, if the tooth was in a Class 3 ramus relationship of Pell-Gregory, in which the entire crown is embedded within the ramus. A Class C depth, which is the relationship to the occlusal plane. In a Class C depth, the third molar is below the cervical line of the second molar. Another factor would be long, thin roots, which is more present in older patients. Divergent, curved roots, narrow periodontal ligament, older patients again. Thin follicle, also older patients. Dense elastic bone, also in older patients. Contact with second molar. Close to inferior alveolar canal. And complete bony impaction would be the last factor to make the surgery more difficult. All of the following are cardinal signs of a localized osteitis or dry socket except one. Which one is the exception? Again, all of the following are cardinal signs of a localized osteitis, dry socket, except one. Which one is the exception? Throbbing pain, often radiating, that is true. That is one of the signs. Bilateral lymphadenopathy, fetid odor, bad taste, poorly healed extraction site. All are correct except bilateral lymphadenopathy. The etiology of dry socket is not absolutely clear, but is thought to develop because of increased fibrinolytic activity causing accelerated lysis of the blood clot. It is most common following extraction of the mandibular molars. Smoking, premature mouth rinsing, hot liquids, surgical trauma, and oral contraceptives all have been implicated in the development of dry socket. Note, careful technique and minimal trauma reduce the frequency of patients developing dry socket. The treatment for dry socket: flush out debris with slightly warm saline solution gently. Place a sedative dressing in socket with eugenol. The dressing should be removed within 48 hours and replaced until the patient becomes asymptomatic. Note, the gauze provides an attachment for the abutment paste so it stays in the socket. 2. Eugenol is the active component in most sedative dressings. And 3. If gel foam or other resorbable material is used, then the dressing does not need to be removed. 4. The medical term for dry socket is alveolar osteitis. Non-steroidal inflammatory analgesics should be prescribed if necessary. Antibiotics are generally not indicated. Dry socket is the most common complication seen after the surgical removal of a mandibular molar. Curating a dry socket can cause the condition to worsen because healing will be further delayed. Any natural healing already taking place will be destroyed, and there is a risk of causing the localized inflammatory process to spread to adjacent sound bone. Before removing a palatal tori, an intraoral picture should be taken. That makes sense. Mandibular torus, if present, should be removed, not necessarily. A stent should be fabricated. A biopsy should be taken. I think a picture should be taken. No, a stent should be fabricated. Maxillary tori present few problems when the maxillary dentition is present and only occasionally interfere with speech or become ulcerated from frequent trauma to the palate. Indications for the removal for the removal include large lobulated tora with a thin mucoperiosteal cover extending posteriorly to the vibrating line of the palate that prevents seeding of a denture and also prevents a posterior seal at the fovea palatini. Other indications for the removal of maxillary tori are chronic irritation, interference with speech, rapid growth, and in patients that have a cancer phobia. Technique for removal. A stent should be fabricated prior to removal of palatal torus. This is done in a study model that has had the exostosis removed. Stent. A double Y incision should be made over the midline of the torus. After careful elevation of the flaps, the torus should be scored multiple times in the anterior, posterior, and transverse dimensions. An osteotome can be used to remove each of those small portions. A large burr or bone file is used to smooth the area. After thorough irrigation, the wound is closed loosely with horizontal mattress sutures. The stent is placed to prevent hematoma formation and to support the flap. Important. The maxillary torus should not be excised en masse to prevent entry into the nose. The palatine bone will come out with the torus. For impacted mandibular third molars, place the following in their correct order from the least difficult to most difficult to remove. For impacted mandibular third molars, place the following in the correct order from the least difficult to most difficult to remove. The least difficult would be mesioangular, vertical, mesioangular, horizontal, and distoangular. This is the exact opposite of impacted maxillary third molars, where the mesioangular impactions are the most difficult, and the vertical and distoangular impactions are the easiest to remove. So the correct order is a mesioangular is the easiest, horizontal is then vertical, and distoangular. So again, this is the exact opposite in impacted maxillary third molars, where the mesioangular impactions are the most difficult, and the vertical and distoangular are the easiest to remove. Surgical principles for removing impacted teeth: adequate exposure, adequate sized flap. So an envelope flap is most often used, but releasing incisions are common. Note, the base portion of the flap should always be wider than the apex portion of the flap to maintain adequate blood supply to the released soft tissues. 2. Bone removal. A through of bone of the buccal aspect of the tooth down to the cervical line should be removed initially. More bone removal may be required depending on the particular tooth. Important: bone is rarely, if ever, removed on the lingual aspect of a mandible because of the likelihood to damaging the lingual nerve. Tooth sectioning. Sectioning of the tooth may also be needed. This is most often performed with a straight burr, such as a number 8 round burr, or with a fissure burr, such as 557 or 703 or 702. 703 are too big, 557 is too thin, 702 is good, but they say 703 or 557. Copious irrigation of the wound is very important, and replacement of the soft tissue flaps completes the procedure. Which two major forces are used for routine tooth extractions? Which two major forces are used for routine tooth extractions? Rotation, pulling, pushing, or luxation? Luxation and pulling. No. Luxation and rotation. Yeah, pulling sounds too weird, but it made sense to me. Anyway, luxation is the loosening of the tooth in the socket by progressive severing of the periodontal ligament fibers. Patience and controlled force are needed, but not brute strength. The force should be applied as low down to the root as possible when extracting teeth. You should support the jaw with your other hand and have a thumb and finger on either side of the tooth being extracted. Note, rotation forces can be used on single-rooted teeth. Teeth are extracted by luxation forces perpendicular to the long axis of the tooth, not by pulling along the long axis. The fulcrum is as close to the apex of the tooth as possible. So the lower possible. Remember, the beak of the extraction forceps is designed so that most of the pressure exerted during an extraction is transmitted to the root of the tooth. Important, when using dental elevators, one should always have respect for the forces generated. Due to the large amount of leverage, dental elevators can generate tremendous forces during normal use and have potential to cause iatrogenic damage. Note, a class 2 lever is used during tooth extractions. You can see the pictures down below. A class 1 lever, you're putting the effort here, the fulcrum or pivot point, and the load. Class 2, and class 3. The root of which tooth is most often dislodged into the maxillary sinus during an extraction procedure? The palatal root of the maxillary first molar. Again, the root of which tooth is most often dislodged into the maxillary sinus during an extraction procedure. The palatal root of the maxillary first premolar, the palatal root of the maxillary first molar, the palatal root of the maxillary second molar, over the palatal root of the maxillary third molar. I would say the first molar or the first premolar. Or the premolar. Yeah, the first molar. The maxillary molar. If an entire tooth of a large fragment of one or a large fragment of one is displaced into the sinus, it should be removed. If the tooth fragment is irretrievable through the socket, it should be retrieved through a Caldwell-Luck approach ASAP. However, only perform this if you know what you're doing. If not, refer patient to an oral surgeon. Note, if a small communication is made with the maxillary sinus during extraction of a tooth, the best treatment is leave it alone and allow the blood clot to form. Postoperative instructions to patients. Avoid nose blowing for 7 days. Open mouth when sneezing. Avoid vigorous rinsing and soft diet for 3 days. If a sinus communication should occur, the following medications may be prescribed for 1 week. Afrin, which is a local nasal decongestant, antibiotics like amoxicillin, and Actifed, which is a systemic decongestant. Afrin, antibiotics, Actifed. I think that's like ephedrine. Actifed. Notes: if the opening is of moderate size, which is 2 to 6 millimeters, a figure 8 suture should be placed over the tooth socket. If the opening is large, 7 millimeters or larger, the opening should be closed with a flap procedure. Remember, the integrity of the floor of the maxillary sinus is at greatest risk when surgery involving the removal of a single remaining maxillary molar. Again, the integrity of the floor of the maxillary sinus is at greater risk with surgery involving the removal of a single remaining maxillary molar. The fear here is possible ankylosis. The Caldwell-Luck procedure eliminates blind procedures and facilitates the recovery of large root tips or entire teeth that have been displaced into the maxillary sinus. When performing this procedure, an opening is made into the facial wall of the antrum above the maxillary tuberosity, maxillary lateral incisor, maxillary premolar roots, maxillary third molar premolar roots. If a large root fragment of the entire tooth is displaced into the maxillary sinus antrum, it should be removed. The used method is a Caldwell-Luck approach. This is a surgical procedure in which an opening is made into the maxillary sinus by way of an incision into the canine fossa above the level of the premolar roots. The tooth or root is then removed. Postoperative management includes figure 8 suture over the socket, sinus precautions, antibiotics and nasal spray, and a systemic decongestion to keep the sinus ostium open and infection-free. Again, this is a surgical procedure in which an opening is made into the maxillary sinus by way of an incision into the canine fossa above the level of the premolar roots. The tooth or root is then removed. Post-operative management includes a figure 8 suture over the socket, sinus precautions, antibiotics, and nasal spray, and a systemic decongestant to keep the sinus ostium open and infection free. If the root tip is small, 2 to 3 millimeters, not infected, and cannot be removed through the small opening of the socket apex, no additional surgical procedure should be performed through the socket, and the root tip should be left in the sinus. If the root tip is left in the sinus, measures should be taken to those taken when leaving any root tip in place. The patient must be informed of the decision and given proper follow-up instructions. Remember, the palatal root of the maxillary first molar is most often dislodged into the maxillary sinus during an extraction procedure. Palatal root of the maxillary first molar. If a root tip of a mandibular third molar disappears from sight while trying to retrieve it, its most likely location is the submandibular space. Other possible locations would be the inferior alveolar canal or the cancellous bone space. Which suture grading below is the thickest? The thickest, 2 zeros. 2-0. Suture size is based on strength and diameter. The gauge of thickness of the suture material is denoted by 0 gradings. As the thickness of the material decreases, the 0 grading rises. Hence, 2-0 is thicker than 3-0, which is thicker than 4-0, and so on. Because suture material is foreign to human body, the smallest diameter suture sufficient to keep the wound closed properly should be used. Most oral and maxillofacial surgical procedures, intraoral suturing, require the use of a 3-0 or 4-0 gauge material. But an extra oral skin surface, finer gauge, is preferred, such as 6-0 or even finer. This helps reduce scar visibility. Note: the primary function of sutures is to help to stabilize the flap during the healing phases without imposing needleless traction on the soft tissue. Which of the following events are correctly paired with the stages of wound healing? Which of the following events are correctly paired with the stages of wound healing? Select all that apply. Fibroblasts lay a bed of collagen. That's a proliferative phase. Platelet aggregation and inflammatory phase? No. Contraction of the wound, remodeling phase? Thromboplastin makes a clot, inflammatory phase? No. I think either the third or the first. Fibroblasts lay a bed of collagen, which is the proliferative phase, or the contraction of the wound, which is the remodeling phase. Well, fibroblasts lay a bed of collagen, that's the proliferative phase, and the platelet aggregation, which is the inflammatory phase, and thromboplastin makes a clot, which is also inflammatory phase. So it was wrong, and the contraction of the wound is not correct. Well, yeah. We'll see. Contraction of the wound occurs during the proliferative phase and wound healing, which is one of the three phases. The three phases are inflammatory, proliferative, and remodeling. Okay, so the inflammatory phase, which is initial lag phase, it's an immediate 2 to 5 days. That's inflammatory phase. In this inflammatory phase, there's hemostasis, which is vasoconstriction, platelet aggregation, and thromboplastin makes the clot. There is inflammation, in which there's a vasodilation and phagocytosis. That's the inflammatory phase. Again, the inflammatory phase is immediately to 2 to 5 days. In this inflammatory phase, it's immediate, and there's hemostasis and inflammation. Hemostasis is vasoconstriction, platelet aggregation, and thromboplastin makes a clot. The inflammatory phase includes vasodilation and phagocytosis. And the second phase is the proliferative phase, or fibroblastic phase. This is 2 days to 3 weeks, in which there is granulation. In this granulation, fibroblasts lay a bed of collagen and fills the defect and produces new capillaries. There's also, along with the 2 days to 3 weeks, there's granulation. There's also contraction, in which wound edges pull together to reduce defect, and there is then epithelialization. So proliferative phase, 2 days to 3 weeks, in which there's granulation, contraction, and epithelialization. In granulation, fibroblasts lay a bed of collagen, fills the defect and produces new capillaries. In contraction, the wound edges pull together to reduce defect. And the third stage of this phase is remodeling phase, which is a maturation phase. There's 3 weeks to 2 years in which new collagen forms. This increases tensile strength to wounds. Scar tissue is only 80% as strong as the original tissue. Factors that impair wound healing: diabetes, protein deficiencies, older age, infections, foreign material, necrotic tissue, ischemia, and tension on the wound. Remember, 3% hydrogen peroxide is the agent of choice for the debridement of intraoral wounds. 3% hydrogen peroxide is the agent of choice for the debridement of intraoral wounds. Sutures placed intraorally are normally removed 1 to 2 days postoperatively, 5 to 7 days postoperatively, 9 to 11 days, or 13 to 15 days. 1 to 2 days. Oh, 5 to 7 days. Wow. Okay. The two basic categories of sutures are 1. Resorbable and 2. Non-resorbable. Resorbable, these sutures are resorbed after a certain time, which usually coincides with healing of the wound. The sutures are made of gut and vital tissue, catgut, collagen, and fascia, and are plain or chromic or synthetic material, e.g. polyglycolic acid, Dexon. Plain catgut sutures are resorbed post-surgically over 8 days, chromic sutures in 12 to 15 days, and synthetic, which is Dexon, sutures is approximately 30 days. Again, plain catgut, 8 days, chromic, 12 to 15, synthetic, more, 30 days. These types of sutures are used for flaps with little tension in children and mentally handicapped patients, and generally for patients who cannot return to the office to have the sutures removed. Now, the non-restorable, these sutures remain in the tissues and are not resorbed but have to be cut and removed about 5 to 7 days after their placement. They are fabricated of various materials, mainly surgical silk, which is monofilamentous, or multifilamentous, in many diameters and lengths, and surgical cotton suture. So, they're fabricated of various materials, mainly surgical silk and surgical cotton suture. Silk and cotton. Silk sutures are the easiest to use, are the most economical, and have satisfactory ability to hold a knot. One of the disadvantages of silk sutures is that they wick bacteria due to their braided nature. Although much more expensive, many surgeons prefer the use of Vicryl sutures. Note: resorbable sutures evoke an intense inflammatory reaction. This is the main reason neither plain gut or chromic gut are used for suturing the surface of a skin wound. When suturing an extraction site in the anticoagulated patient, a non-restorable suture is recommended. Resorbable sutures are accompanied by inflammatory responses and increased fibrinolytic activity, which may potentially result in clot breakdown. Again, resorbable sutures are accompanied by inflammatory response and increased fibrinolytic activity, which may potentially result in clot breakdown. Two basic methods of wound healing, primary and secondary. The primary intention wound healing, also called primary closure, involves minimal re-epithelialization and collagen formation, allowing the wound to be sealed within 24 hours. Healing occurs more rapidly, with a lower risk of infection and with less scar formation and less tissue loss than wounds allowed to heal by secondary intention. Examples include well-repaired and well-reduced bone fractures. Now, secondary healing. Secondary healing is also called secondary closure, involves a re-epithelialization via migration from the wound edges, collagen deposition in the connective tissue, contracture and remodeling. The site fills in with granulation tissue. Healing is slower and results in scarring and wound depressions. Examples include extraction sockets, poorly reduced fractures, and large ulcers. Regardless of the flap design used, certain principles should be followed while incising and reflecting the gingiva. With this in mind, the determination of a vertical incision at the gingival crest must be, again, regardless of the flap being used, certain principles should be followed while incising and reflecting the gingiva. With this in mind, determination of a vertical incision at a gingival crest must be mid-buccal to the tooth, at the line angle of the tooth, mid-lingual to the tooth, or beyond the depth of the mucobuccal fold. Okay, I don't understand it, but definitely not beyond the depth of the mucobuccal fold. Let's read it. Yeah, at the line angle of the tooth. That's the answer. So the question was, regardless of the flap design used, certain principles should be followed while incising and reflecting the gingiva, with this in mind, determination of a vertical incision at the gingival crest must be at the line angle of the tooth. Let's read the explanation. Regardless of the flap being used, certain principles should be followed while incising and reflecting the gingiva. These include: incision should be made with a firm, continuous stroke. Incision should not cross underlying bone defect that existed prior to surgery or were produced by the surgery. Vertical incisions are made in the concavities between bony eminences. Vertical incisions are made in the concavities between bony eminences. That's not. Okay, let me see. Okay, yes. So basically, don't make the incision in a bony eminence. Okay. So that's. I thought it was the other way. I was understanding that it was saying the other way around. That's why I didn't. I had to read it again. So anyway, not to be made between bony in bony eminences. Termination of vertical incision at the gingival crest must be at the line angle of the tooth. Vertical incision should not extend beyond the depth of the mucobuccal fold. The base of the flap must be as wide as the width of the free edge, which is the supraperiosteal vessels running vertically should not be transected. Again, supraperiosteal vessels running vertically should not be transected. And that's why the base of the flap must be as wide as the width of the free edge. Periosteum must be reflected as an integral part of the flap. Important, the correct positioning for ending a vertical releasing incision is at a tooth line angle, not over the buccal surface of the tooth. Again, important, the correct positioning for ending a vertical releasing incision is at a tooth line angle, not over the buccal surface of the tooth. If it ends over the buccal surface, the edges are difficult to approximate, and this may lead to periodontal problems. Incision should never cross bony prominences, as this increases the chance for wound dehiscence. The types of incision used in oral surgery are three: linear, releasing, or semi-lunar. The linear is a straight line incision used for apicectomies. The releasing is used when adding a vertical leg to a horizontal creation incision for extractions, augmentations, etc. And the semi-lunar, which is a curved incision mostly used in apicoectomies, just like the linear. The basic principle of oral surgical flap design. The flap design should ensure adequate blood supply. The base of the flap should be larger than the apex. Reflection of the flap should adequately expose the operative field. The flap design should permit a traumatic closure of the wounds, and the flap should be closed over bone if possible. Next, while attempting to remove a grossly decayed mandibular molar, the crown fractures. What is the recommended next step to facilitate the removal of this tooth? Use a larger forceps and luxate remaining portion of the tooth to the lingual. Separate roots. Irrigate the area and proceed to remove the rest of the tooth. Place a sedative filling and reschedule patient. No, separate the roots. This can be done with a chisel, elevator, or most easily with a burr. Teeth with two or more roots often need to be sectioned into single entities prior to successful removal. A popular method of sectioning is to make a burr cut between the roots, followed by inserting an elevator in the slot and turning it 90 degrees to cause a break. Roots can be removed by closed technique. The surgeon should begin a surgical removal if the closed technique is not immediately successful. Indications for surgical extractions after initial attempts at forceps extractions have failed. Patients with dense bone, older patients due to less elastic bone, short clinical roots with severe attrition, like in Bruxers, hypercementosis or widely divergent roots, extensive decay which has destroyed most of the crown. Teeth are resistant to crush but are not resistant to shear. Therefore, place the beaks of the forceps opposite to each other at the same level of the tooth. The beaks should be applied in a linear line parallel with the long axis of the tooth. Remember, when luxating a tooth with forceps, the movements should be firm and deliberate, primarily to the facial with secondary movements to the lingual. The maxillary first bicuspid is the least likely to be removed by rotation forces due to its root structure. Obviously, molars are not removed by rotation. Notes: it is recommended to use a bite block when removing mandibular teeth to diminish pressure on the contralateral TMJ. Distilled water is not used for irrigation because it is a hypotonic solution and will enter cells down the osmotic gradient, causing cell lysis and rapid death of bone cells. Buccal to lingual movement is not efficient when removing a mandibular posterior teeth. Buccal to lingual movement is not efficient when removing mandibular posterior teeth because buccal to lingual movement is not efficient when removing mandibular posterior teeth because mandibular bone is too dense and bone does not repair in a fashion similar to that of maxillary bone. The tooth of the zygoma can interfere with efficient removal of a maxillary first molar.